Care website. And we'll remind you of that a couple of times, just in case people join or leave at some point in the meeting. So I'll turn it over to Olivia to do the MaineCare.
Hi, good afternoon, everyone. Thank you for joining us on this very nice and brisk Friday afternoon. My name is Olivia Alford. I'm the Director of Value-Based Purchasing at MaineCare. I recognize some of the folks from the attendee list, so that's nice to see. In addition to myself from MaineCare, it looks like we have some representation from MaineCare Policy, as well as the MaineCare Rate Setting Unit, which of course is the main place where this work sits within the office. I just wanted to give an overview of this project as a whole really quickly and touch on a few foundational items for the discussion today. So this comprehensive rate system evaluation is in two parts. And all of this is in acknowledgement that MaineCare has a wide array of different rates we pay for the many different services we provide. And not just the rates we pay, but how those rates were developed originally, how those rates are updated or not updated on any kind of set schedule, whether those rates are tied to Medicare rates, whether they're based on a state average from other Medicaid agencies, whether they are cost settled. You know, the variance that we have is quite significant. And so in order to tackle this from a more comprehensive strategic perspective, we've engaged with Myers and Sopher to do two things. So phase one, cataloging all of the MaineCare rates for all of the services, you know, the MaineCare Benefit Manual services, and establishing how those rates relate to other payers like Medicare, commercial payers, and other state Medicaid agencies that are similar to Maine in their delivery and demographics. And not only how the rates compare, but how does the methodology compare? So how do they pay for how do they pay for those services versus how do we pay for those services? So are we paying 15-minute increments when other states are paying a per diem? Are we doing a cost settled process where other states do a case mix process, a prospective case mix process? So they're going to do an evaluation of all of that and come up with a report. And part of what you're a part of today is that phase one assessment, where we're talking about how we pay. Today is not about what we pay, because that aspect of the actual rate amount is part of phase two, when Myers and Sopher will come back to us with that catalog and the nice comparison to other payers, and then we'll have a conversation with you all about the actual rate amounts. So, and after that, we'll do a lot of prioritization. So that'll be, a lot of the real meat of it comes really after all of this information has been gathered. So next slide. So yeah, just to reiterate, we're not talking about specific rate amounts today. We're talking about methodologies. And we are gathering feedback throughout this week. You're the last session of the week. And we are not going to be responding to questions today, but everything is being transcribed and will be part of, again, this comprehensive report for phase one. Next slide. Okay, and so just quickly, some of the questions today, there are 5 discussion questions which you should have received in advance. But one of the questions talks about value-based purchasing, and value-based purchasing is important when we're talking about rate methodology. So we want to just quickly go over what that means in the context of MaineCare rates and try to relate it a little bit to the services for ambulatory care clinics or clinic services. So value-based purchasing is essentially trying to structure payments for services that incentivize or require there be a connection to value. Value is subjective in what you're looking for, but it's really very simplistically an actual relationship between quality and cost. So when we're looking at value, we're looking to see that if, for example, the cost of services stays the same, to get more value, we need to have quality go up. And if quality stays the same, to get more value, we need costs to go down. We want to see quality go up, of course, but we also want to do so in a way that is viable for everyone involved. So when you talk about value-based purchasing, part of my job is to think about this more in a service specific way, where we look at what are the policy goals, what are the policy objectives, how can value-based purchasing be used in a positive way for providers and for payers as MaineCare to incentivize innovation in care, efficiencies in care, lessened administrative burden. Again, all based on the premise that we want to look at the quality and cost outcomes and not focus necessarily on what we do today, which is on volume. So next slide. As you're familiar, fee for service is not a value-based system. There's no connection to quality or cost. The more you provide, the more money you're paid. That's a volume-based system. And we want to move away from that. Next slide, I will show you a little bit more about how we are measuring our progress in this regard. You may have seen this visual before. It's from the Healthcare Payment Learning and Action Network. It's the national standard for how we talk about alternative payment models, which are the vehicles you use to get to value-based purchasing. So fee for service over on the left is the orange column. That's where we are today. For the most part, MaineCare has 80% of our spend approximately in fee for service arrangements. Even if you're paid not on a 15-minute increment, if you have no tie to quality or cost or utilization outcomes, it's still fee for service. So even if it's per diem, it still is considered fee for service if there's no tie to quality. And then you move up to the green, where you're looking at more broad accountability for a broad set of services, populations-based payments, and there's lots of different models between the orange and the green, which we utilize today and which are used nationally. And some of the ones that you may be more familiar with are things like pay for performance, where there's an incentive for meeting a predetermined benchmark on a set of quality measures, and you receive an incentive payment to do that, or an incentive penalty in some cases. Accountable care organizations are an example of a Category 3 model for the most part. So that's a little bit about the framework of how alternative payment models are established and measured nationwide. We have a goal to move MaineCare payments to be 40% in Category 2 or higher by the end of 2022, so in 2 short years. And so we are essentially in these conversations also looking to hear from you today a lot about how is the current methodology impacting your ability to deliver high quality services, to deliver services with the appropriate amount of administrative burden. How can alternative payment models support you in doing the good work you do better by creating some ability to focus more on outcomes and quality than on volume-based billing. That's one of the drivers today. And with that, I will hand it over to Julia.
Great, thank you. So this is the 5 general questions that we're going to be going over today. Just to give you some navigation tips for the WebEx, we are going to be using the raise your hand method for you to ask to be unmuted to be able to provide a comment. It looks kind of like a little hand. It's to the left usually of a symbol that looks like a megaphone. Depending on how you have your panels, it's somewhere usually around where the chat and QA panel pop up. If you want to see the attendees, you can click on the panel that says participants, and then there's a view all attendees, and that will let you know who all is in the meeting today. Go ahead and go to the next slide. Our role in this is really to introduce the discussion questions and then to do a little moderation and time management to make sure we can gather all the information, and we'll be recording, like I said, we will be recording the meeting, and that will be linked to the MaineCare website. Your role is to introduce yourself and let us know the service that you're giving a comment about, so that we can associate the correct feedback to the right services. Respond only to the discussion topic that's being discussed generally. If someone has said something before, you can note that you agree with them. And again, we're really focused more on the methodology. go to the next slide. Phase 2 of the meetings, which will be held in November, will be the time at which we talk about payment levels. After, there will be the phase 1 report to respond to that includes the benchmark payment rates, the catalog, and a recommendation of services for alternative payment models. If you don't wish to speak today, or your sound isn't working, or you remember something you want to tell us later, you can submit any written comments at ratesettingeval@maine.gov. Go ahead and go to, okay, so we're going to start the discussion. So when you think about your services and the methodology for the services you provide, we're really wanting to know, is the methodology transparent and easily understandable? Does it create opportunities for you to efficiently provide your service? And does the methodology reflect how you deliver services? For example, do you provide a bundle of services, but you have to bill for them individually? Or do you bill for a 15-minute increment of time when your services typically are 1 or more hours? So if you could just click the raise hand button, or if you aren't able to find the raise hand, you can chat at us in the chat box, and Jillian can unmute you. So anyone who wishes to provide comment on this topic can raise your hand or chat in the chat box to us.
Okay, our first comment, I have Nicole Clegg.
Hi, everyone, and good afternoon. My name is Nicole Clegg, and I am representing Planned Parenthood of Northern New England. We're a healthcare provider located in Southern Maine and treat about 12,000 people in the state. And I wanted to sort of speak to, I think, the second question in particular, which is, as a provider, first, we are a provider that sees anyone, regardless of ability to pay, and have maintained that commitment, especially throughout the pandemic. And we provide a wide array of services to our patients. And, while we are a family planning provider, much of what we also provide can be, ascribed to as primary care. When we sit with a patient, we screen them for substance use. We talk about intimate partner violence. We talk about smoking cessation, obesity, and BMI, reproductive life planning. There's a wide array of what we cover in our visits. Some of these, aspects of the visit can be less than 3 minutes. And, when you're looking at sort of trying to apply individual codes to everything that we're doing, we're just not getting it's the full value of the visit that we're providing with our patients isn't being realized through the system that we have with the current family planning fee schedule. So I just wanted to sort of really highlight and lift up sort of the unique role that we play as a safety net provider, and sort of the breadth of what we do with our patients is really missed. It's not sort of fully appreciated by the current system that we have.
Okay, thank you, Nicole. Next up, I have Evelyn.
Hi, can you hear me okay? Can you hear me?
Sorry, I muted myself. Yes, we can hear you.
Okay, good. Sorry, I just want to make sure. Hi, thank you for thanks for having this session today. I really appreciate it. My name is Evelyn Keltiga. I'm the Senior Vice President of Program Services at Maine Family Planning. Just as a quick background, we're the statewide organization that oversees all the family planning services around the state. Nicole's in Southern Maine. That's one of our subrecipients, as well as we have a network of subrecipients across the rest of the state. We ourselves operate 18 health centers. So altogether, we have about 45 health centers across the state of Maine, including FQHCs, ourselves, Planned Parenthood, some school-based health centers. So that's kind of the thumbnail sketch of who Maine Family Planning is. We've been around for 40 years. We are the grantee for the state funding that comes to us, and we make available to our subrecipients. So I just want to echo what Nicole is saying, and also to point out that For women 15 to 44, we are their only healthcare provider. In fact, the data says the majority of women, 6 out of 10 women in that age group, only seek us, family planning programs such as Planned Parenthood ourselves, for their reproductive health care, which really, as Nicole said, is broader than simply providing a birth control method or an STD test. So just want to echo that. And as she was saying, it just sometimes wanted to, as you're thinking about the methodology, how really looking at us as really, for those women, a full service provider. We have a tremendous network in terms of quality and coordinating of care, in terms of getting people to the right provider, whether it's for domestic violence issues or substance abuse issues or simply other primary care issues that aren't part of our wheelhouse. We make it our goal to get people to the right place, so, in terms of those sorts of care. And it also, it's very important that men and women and teens have access regardless of their ability to pay. So unlike other providers, no one's turned away because they can't pay their bill that day. They will get the method that they want, they'll get the services they need, and then we will figure out a way to work out some sort of payment system if they fall into our sliding fee scale, which is based on federal poverty level, household size, and household income. So thank you.
Thank you, Evelyn. Let's see. I'm not seeing any new hands. Nicole, did you have another statement? I see your hand still up.
Oh, sorry. I think maybe I need to click myself off.
No problem. Just wanted to make sure. I know sometimes, when we ask a question, someone else's response can click something and you want to make another comment. Okay, I am not seeing any new hands, Julia.
Okay, so we can go to the next question. So when you think about the payment methodology, does it create the right incentives for quality and access of care, primary and preventative care, integration of care coordination, how members use services, and is it structured in a way that makes it easier to avoid abuse and fraud? So if you would like to make a comment, please just raise your hand.
Okay, I've got Evelyn.
Hi, thanks again. This is a great question. I think, as I mentioned earlier, we do a lot of coordination of care, even though we're not providing the garden variety primary care services. So I think, as you probably know, we're in Chapter 30, we're fee for service. And so the rates are established. Basically now the rates are right from the physician chapter. So we get the same payment as a physician does. So the physician services do. So I might suggest, as you're thinking about methodology going forward, if you would consider for family planning ourselves a prospective payment system, not unlike what the FQHCs use, because we think that would probably more accurately capture all the things we're doing, in addition to what Nicole said earlier about the breadth of services we make available, as well as the fact that we are really ensuring access to care coordination. It's very important that our patients are getting the services they need. As you know, we provide confidential services, and often it's been our experience that patients who have primary care services, often our primary care provider will seek us out for services that they really feel that they get the level of confidentiality and, frankly, no judgment zone kind of thing. That's been repeatedly what patients have said why they've sought us for particular issues, is because of the importance of that piece of it. And I know that's very important to MaineCare. We've always had a great partnership with you folks around those sorts of issues. So I just wanted to suggest a consideration of a prospective payment system. And we think that would adequately reflect, obviously tied to quality measures and things like that. That's very important to us. So we would enjoy that conversation.
Okay, thank you, Evelyn. I'm not seeing any other comments or raised hands on this question.
Okay, great. If you want to move, thank you. So when you look, this one is about equitable payment methodologies. So looking across all of the service area, do you believe that your rates are treated equitably, the methodologies are treated equitably within your service area across providers? Are the fee schedules determined and updated in an equitable, uniform way? Is there a similar amount of administrative burden, similar access to incentives? So if you would like to give a comment on this question, please raise your hand.
Okay, I've got Evelyn.
Great, thank you. So I think a couple of things. One, just to point, I know we're not talking about rates, but in terms of methodology, we've not had any methodology applied to our rate setting in a number of years. I think Tony Marple was the head of of MaineCare. That's how far back we go in terms of any sort of changes. So I would say in terms of updating, it's been a long time. The one other thing is, of course, in Chapter 30, that's sort of our contract with MaineCare. When we've approached folks to update a CPT code in order so we could make those services available to the MaineCare members, it's been arduous and time-consuming at best. One example is that there is a CPT code for rapid hepatitis C testing. That's a point of service test where you can make it available right in your practice. And we have been unsuccessful in getting that CPT code added to our contract. So that really, I think, has been an administrative burden and limits our ability to provide what we would consider evidence-based care to to your members and our patients.
Okay, thank you, Evelyn. I am not seeing any other hands up or anything in the chat, Julia.
Okay, we can go to the next. So our last two questions are on, the first one is asking if you believe your methodology is consistent with value-based purchasing or with any value-based purchasing approaches that you have in place through other payers or are aware of. And then the second question is, are there particular administrative burdens MaineCare specifically places on you that related to the methodology that you feel are burdensome, things like particular coding, billing, or reimbursement? And you can go ahead and raise your hand if you'd like to comment.
Okay, I've got Evelyn.
Hi, I'm just calling because I know our billing manager, Rhonda. Don't mean to call you out, Rhonda, but I know this is your sort of your bread and butter here. I didn't know if you wanted to make any comments about anything that I've left out from this particular question.
Hi. So yeah, it is actually, we have been having an easier time with this administration, getting codes added. Originally, I had started working on having just a UNA strip added back in 2016, and we waited 3 years, and we were told that no codes could be added to our fee schedule. So when the limited family planning benefit came in, and was finally approved, there was a lot of codes in there that wasn't in the family planning contract. So believe it or not, we could not bill those codes for 3 years, even though they were approved codes, because they weren't in the family planning contract. So right now we're okay, but looking down the road, you know, if things change, I do not think it's equitable on how codes are added to the family planning contract compared to other ones. And of course, on our end, we do run into situations that don't seem to be able to be resolved. A lot of our services require an FP modifier. I don't know if you guys are aware of what those are, but it's for the 90-10 split. But Medicare does not allow an FP modifier. And there are many patients right now that have dual eligibility. They have Medicare and Medicaid. So we have to submit to Medicare first without the FP modifier in there. And I have to try to catch it midstream to add it before it's transferred over to main care. Or else main care denies it, sends it back, says it has to be billed separately, and then I have to start it all over again. So those can be quite time consuming and burdensome. But that's it for me.
Thank you, Rhonda. Okay, I'm not seeing any other hands up or responses in the chat.
So this, because we were pretty short today, I just want to open it up here at the end. If there's anything that you feel is important for us to know that you haven't already mentioned in response to the questions, I'll open it up at this time to hear any of those. So if you would like to tell us something, please raise your hand so that Jillian can unmute you.
Okay, thank you. First up, I've got Nicole Clegg.
Hi, thank you. And apologies, I'm on the road, and so I missed some of what Evelyn shared. So I may end up repeating some of what she's already said, but I did want to, one, emphasize in the prior question that was asked, and that was when I lost reception, the aspects of, care coordination that is being conducted at family planning health centers, including Planned Parenthood, that really isn't, appreciated or acknowledged. And I also sort of wanted to, raise the question I have around presumptive eligibility and how that's going to be implemented for family planning services, sort of the intersection there when we are looking at the payment methodology, to flag that as sort of an outstanding issue for us. And I would also echo what Evelyn shared with regards to sort of the
Ooh, sorry, Nicole, it looks like you might be breaking up a little bit.
are much more likely to disclose issues in our healthcare settings than they are in a primary care setting. And again, it's sort of because of well, I'll let there that you may not be able to hear me and submit the rest of the comments. I don't know if you can hear me.
Oh yes, I can hear you again. You broke up a little bit towards the end.
Sorry. No, I'll just do my best to submit the rest of these as written. You'll be able to hear me.
Okay, no problem.
Well, thank you everyone for joining us this afternoon. We really appreciate the time you took out of your day to give us comments. If you have anything that you forgot to say or that you wanted to tell us in writing, please don't hesitate to contact us at ratesettingeval@maine.gov. And I hope you have a lovely weekend. Thank you for joining us.